Hi, beautiful people. How are ya? I'm Dr. Pammy Jean. I hope you're having a great day. I ended part one with this information. Here's the important part. Autoantibodies targeting extracellular matrix 1 protein and the basement membrane zone in VLS have been identified. Experts favor a T cell mediated pathogenesis, making this an autoimmune condition. Now, I would say in the medical literature that it's about half and half, but this is very new information, so I think it will become widely considered an autoimmune condition. And it's really funny because my gynecology nurse practitioner that does my yearly checkups, when she saw the, I'm guessing, lesion, she was like, that wasn't there the last time, which the last time I had this checkup was a year ago. And so she got the doctor to take a look at it. And the doctor immediately said, lichen sclerosus. So we haven't done a biopsy. Don't know if I'll need one. The literature is mixed on that as well. If it's clear that it's by, the signs, then a biopsy isn't necessary. But if the signs aren't real clear, then a biopsy is necessary. She wanted to do a biopsy. The doctor said just start on the medication first, and then I go back. Well, it's been a week or two. Time flies. I don't know. And so a month from that date, we see whether or not the medication I'm using is taking care of it. And hopefully it is. I would love to go into remission. That's my goal. But about 31% of patients with VLS, as I stated in the last video, vulvar lichen sclerosus, I'll just say VLS. So about 31% of patients have anti-nuclear antibodies or ANA. Pretty much every time they check me for it, I do have it. And most of us do, I think, with fibromyalgia. Maybe not every single time. It's really odd, isn't it? But thyroid peroxidase and thyroglobulin antibodies are also present in 16 to 19% of cases. Positive gastric parietal cell antibodies have also been found in 5.3%, and 5.9% had low B12 levels. That's interesting. Just did a video on B12. It's also thought that infectious agents may be involved, such as viruses or harmful bacteria. And my nurse practitioner explained to me, after she asked me if I'd heard of lichen sclerosus, which I have, because it's, shows up in the literature as an overlapping condition in people with fibromyalgia. But, that's not going to happen to me. So isn't that how we think? But she said that when you have one autoimmune condition, you are more likely to have another one or many. So she was referring to my fibromyalgia, considering it as an autoimmune condition, which I found really interesting. That's maybe how many doctors and maybe nurse practitioners accept it. So, anyways, I just wanted to throw that out there to you because I thought that was interesting. But it's also thought that infectious agents may be involved, such as viruses or harmful bacteria. On top of that, statin use has been implicated. Quote, the metabolic role of statins may be complex, as statins have been associated with glucose dysregulation, unquote. So you can find all of my research articles that I read in the comment section below. It becomes really overwhelming when I have to copy each one and show it on the screen because a lot of times I am using multiple articles, and I am in this case. So, increased statin usage among VLS patients suggests the presence of underlying dyslipidemia, meaning unhealthy levels of fats in the blood, and metabolic dysregulation. I am taking a statin, so yes, that's definitely going to be a conversation with my family nurse practitioner. But the metabolic dysregulation is a good reason to get sugar out of my diet. I take atenolol because of the neurocardiogenic syncope, the statin, to keep my blood pressure at a normal limit and not low. It was falling too low and causing me to faint. So that's the purpose of it. And now I'm thinking I need to switch back to midodrine. I'm taking atenolol because it's cheap and I didn't want to pay whatever it was, $20, $50, whatever it was a month on the midodrine, but that's really not worth it to be cheap when it contributes to this disease, right? So, no biggie, I'll just switch. In addition, hormonal influences have been proposed, and also being overweight, obese, or having blood hypertension. Immunological dysreactivity and autoimmune response appear relevant pathophysiological mechanisms. Yeah, there is a total abnormal activity. Let's talk about its prevalence. The disease occurs at all ages and in both sexes, but is more common in females. The exact prevalence of VLS is unknown, but it is estimated to be between 0.1% and 3% in the prepubertal and postmenopausal periods. Interesting. But about 40% of women with VLS will display onset of symptoms and cutaneous changes during their reproductive years. Wow, that would have been horrific. Regardless, VLS is one of the most common referrals for vulvar distress and/or structural changes. About 2 to 5% of VLS women develop squamous cell carcinoma, and there's a lifetime risk of cancer. A family history of VLS has been shown in several studies. The rate of first-degree relatives affected with VLS ranged between 5.4% and 12% of the patients. As stated earlier, there is support for a genetic link. In patients with VLS, other common conditions can overlap, including autoimmune diseases such as Hashimoto's, chronic lymphocytic thyroiditis, or autoimmune thyroiditis. psoriasis, vulvar carcinoma, vitiligo, Graves' disease, and autoimmune diseases are known to run together in groups. So you can expect to get another one if you get this one. The prevalence of other autoimmune diseases in VLS is around 34%. It's pretty high. In a 2012 study, other comorbidities found in VLS are overactive bladder at 15.3%, urinary incontinence at 38.6%, stress UI at 27.9%, inflammatory bowel disease at 1.9%, constipation at 32.5%, IBS at 19.5%, thyroid dysfunction at 33.1%, interstitial cystitis at 2.6%, TMJ at 13%, vulvar pain at 83.1%, and drumroll, fibromyalgia at 9.1%. All of these are significantly different from the general population, other than the overactive bladder. In a 2020 study, patients with VLS had fibromyalgia, hypertension, peptic ulcer disease or gastroesophageal reflux disease, urinary incontinence, thyroid disease, and erectile fissures, kidney or liver problems, or cancer. But the most strongly associated were thyroid disease and anorectal fissures. Diagnosing VLS may require a biopsy when the clinical picture is not diagnostic. One look at my skin, as I said, and the gynecologist said it was VLS. My nurse practitioner and doctor determined that a topical corticosteroid for the next month was necessary, and then return for a checkup. If progress isn't made, as I said, a biopsy will be necessary. I know that in most cases, a biopsy should be performed, no matter whether they have determined it by the signs. So we will see when I return. I think I'm going to ask for it. I think it should be done. It just seems like it should be done. A prompt diagnosis has been shown to have a favorable consequence on the course and prognosis of VLS, since early intervention is crucial. The ideal treatment should aim at inducing relief of symptoms, reversing the signs, and preventing further anatomical changes, including tumorigenesis. Due to its progressive course and potential evolution toward cancer, all VLS cases should be treated even when asymptomatic. So if you're asymptomatic, meaning you don't notice anything by how you're feeling, but a doctor is suspicious it's VLS, you should do treatment. Don't think that just because you don't have symptoms, you still need to keep up with treatment. The chronic nature of VLS is one of its main troublesome features because recurrences are unavoidable when treatments are discontinued. So even when you go into remission, you still have to do treatment just to keep it at bay. Therefore, long-term maintenance of signs and symptom remission can be achieved with an effective initial therapy and additional courses of treatment. Minimizing the risk of scarring and cancer development is the goal of treatment. An increased risk of genital cancer is known, and a significant reduction in quality of life is also known. This isn't an easy disease to deal with. Early use of topical corticosteroids may reverse skin changes and prevent both scarring and tumor evolution. Despite this, delayed diagnosis is common. That's sad. The first line of treatment, as the gold standard, is a topical corticosteroid, a steroid. The most common is clobetasol. That's what I'm using. Or if that doesn't work, or in addition to, your healthcare provider may recommend a calcineurin inhibitor, such as tacrolimus ointment, or also called Protonic. Please follow your doctor's instructions. Your doctor may recommend an oral antihistamine at bedtime to help control the itching as you sleep. I've already been doing that, not for any itching, but just for my allergies. So, how about that? Dilators are helpful to get you to a place of enjoying a pain-free sexual experience. For more information on this, please visit lostlabia.com. I put the link in the description section and sign up for their free ebook. I don't think I can explain this any better. The link is in the description for the ebook. And she also does videos on YouTube, which have been very helpful to me. She went 10 years without a diagnosis. I can't imagine that. There are other treatments under investigation, such as laser treatment using various wavelengths, and also treatment with biologics is also under investigation. That's interesting. Using soft, unscented toilet paper without dyes is recommended, and avoid scented detergents. It's not recommended to use over-the-counter medications like Lenitive, which is a soothing or pain reliever, herbal products, topical antihistamines and anesthetics, and perfumed products due to an increased risk of inducing contact sensitization in VLS patients. Personal hygiene is important, but the application of irritating soaps, shampoos, and bubble baths should be avoided. Simple emollients are necessary, such as topical ointments like Vaseline or Aquaphor are often recommended to keep a barrier from urine stinging the skin, so in between your other treatments, and prevent the skin from sticking together, and also to provide a moisturizing experience. I feel this is essential. Also, an ointment before swimming or bathing may be useful. Other patients find creams or gels more beneficial. These are used in conjunction, as I said, with the corticosteroid. If patient is incontinent, the skin should be protected with a barrier emollient. So keeping the skin dry as possible is needed. Ointments are preferred to cream on the anogenital skin due to providing less irritation and less sensitization. But wearing cotton underwear is needed for breathability of material. Some people prefer silk underwear. That also works, but anything else might exacerbate the symptoms. Avoidance of trigger factors such as trauma to the area, piercings, and unnecessary surgical interventions. Also, irritants should be avoided, such as excessive water exposure or cleansing products, synthetic and tight clothing, or use of wet wipes at the affected area. If you are struggling with your mental health and this disease, I'm here to tell you that you're not alone. You are loved, and you can get through this. We'll get through this together. But please seek out a mental health counselor who can help you in so many ways. I'm currently in the process of finding one myself. So I hope this made sense to you. I send you gentle hugs and support. Love you.